management of post-operative pulmonary hypertensive crisis following pediatric cardiac surgery. So, in introduction, about the whole spectrum of the diseases, we can say that the pulmonary vascular diseases are a heterogeneous group of disorders with multiple causes. Pulmonary vascular disorder caused by conditions that directly affect the pulmonary vessels, as in idiopathic pulmonary arterial hypertension, or by disorder outside of the lung, or as in pulmonary hypertension associated with lung disease and hypoxemia. The pulmonary artery pressure and pulmonary vascular resistance progressively rise in these conditions, leading to ultimate right heart failure and death. Over the years, improvement in understanding the pathogenesis of this disease resulted in the development of targeted approach to the treatment of pulmonary arterial hypertension. Survival advantages has also been shown with some of the pharmacological agents. Now, some basic review of the circulation. The pulmonary circulation consists of arterioles, capillaries, and veins, and the major role of pulmonary circulation is to bring blood into close proximity of the alveolar air so that the gas exchange can occur. The pulmonary vascular bed receives the entire cardiac output, and the total system is high volume and low pressure system. While the bronchial circulation, the bronchial arteries originates of the aorta and supplies the airways, which are approximately very minimal 2% of the cardiac output, but the system is low volume and high pressure system. 1/3 of the blood flow through the bronchial circulation empties into the azygos vein, while the rest 2/3 of the blood flow empties into pulmonary capillaries. Now, pulmonary circulation in the pulmonary vascular resistance PVR is a measure of the impedance to the flow in the pulmonary vasculature. PVR depends on the pulmonary artery pressure, left atrial pressure, and the cardiac output. Normal pulmonary artery pressure is around, we can roughly say this, 25/8 millimeter of mercury, while mean pulmonary artery pressure is 15 ± 3 millimeter of mercury. The pulmonary artery pressure, as previous slide we can see, is equal to cardiac output into multiplied by the pulmonary vascular resistance plus pulmonary venous pressures. So any change in the cardiac output, any increase in the cardiac output, any increase in the pulmonary vascular resistance, or any increase in the pulmonary venous pressure, that is, which indirectly indicates the left atrial pressure, will lead to increase in the pulmonary artery pressure. The pressure gradient driving flow through the pulmonary circulation is rather small, at about only 7 millimeter of mercury. That is the gradient between the mean pulmonary artery minus pulmonary venous pressure. This is much lower driving pressure than the systemic circulation, because the gradient in the systemic circulation is about 90 millimeter of mercury. Although the blood flow through the pulmonary circulation is essentially the same as the blood flow through the systemic circulation, the pulmonary vascular resistance is much lower, around 10 to 15 fold lower than the systemic vascular resistance. This overview of the whole picture, that is, the left side is pulmonary circulation. We can see the pressure differences at the capillaries, arteriolar end of the capillaries in pulmonary circulation, and the arteriolar and venous end of the capillaries in the systemic circulation, so that the pulmonary circulation. Yes, sir.
Huh? Yes or no? Huh?
The overview of the pressures in both pulmonary and systemic circulation, we can see in this slide, where the arteriolar and venous end of the capillaries, we can see and compare the pressure differences in both circulation. Likewise, in the pressure curves of the right side of the heart, the pressure curves on the right ventricle and pulmonary artery pressure tracing. If we trace in a x-axis with time and in y-axis with the pressure, we can get the aortic pressure curve, right ventricular curve, and pulmonary artery curve, and compare according to the pressure time curve. Now, pulmonary artery hypertension, the earlier definition was an abnormal increase in mean pulmonary artery pressure of 25 millimeter of mercury or more at rest, or increase in mean pulmonary artery pressure more than 30 millimeter of mercury during exercise as assessed by the right heart catheterization. During the 6th World Symposium in 2018, the hemodynamic definition of the pulmonary artery hypertension was revised, and the cutoff was brought down to 20 millimeter of mercury. Now the pulmonary artery hypertension is the mean pulmonary artery pressure more than 20 millimeter of mercury with a OH pressure of less than 15 millimeter of mercury, and pulmonary vascular resistance is more than 3 times of the Woods unit, that is 80 into 3 is 240 times. Just an overview of the chamber pressure in pulmonary artery hypertension. There is 3 components, so that is enlarged proximal pulmonary arteries, there is right ventricular hypertrophy, and right atrial dilatation. Now, pathophysiology of the condition. We all know that hypoxemia causes vasoconstriction in pulmonary bed. So there is decreased perfusion worsens that hypoxemia. Hypoxic alveoli causes arterioles to vasoconstrict further to preserve the ventilation perfusion matching. Likewise, the pulmonary pressure increases and gradually it becomes sustained high pressure. Right ventricle works harder and develops right ventricular hypertrophy and overload as a consequence of this process. Pathogenesis of the disease starts from the various risk factors and associated condition like collagen vascular disease, some congenital heart disease that we'll discuss later, portal hypertension, some infection, HIV, drug and toxin induced pulmonary hypertension, pregnancy. Along with this, there is some susceptibility, which is genetic susceptibility for some gene mutation. When they combines with the genetic susceptibility and associated condition, there occurs vascular injury, which is mainly the endothelial dysfunction, which leads to various decrease and increase in the vasoconstriction and vasodilator synthesis and production, which we'll discuss later, which ultimately leads to the smooth muscle hypertrophy, that smooth muscle dysfunction, and then the disease progressed to the irreversible phase, that is severe smooth muscle hypertrophy with intimal hyperplasia, and ultimately resulting in situ thrombosis and may result in plexiform lesion or angiomatoid lesion, when that is called the advanced vascular lesion, which is the irreversible disease. In this slide, we can see the pathological picture of this pulmonary arteries, how it becomes fetal, then postnatal, and then in case of pulmonary hypertension in early phase, there is marked medial hypertrophy, while in case of late disease, there is medial hypertrophy plus intimal hyperplasia plus fibrosis. The plexiform lesions in a patient with pulmonary hypertension is seen, we can see in the pathological slide, while in the left, the vascular changes of the pulmonary artery hypertension. And
the slide is not moving. Yeah. Okay.
Okay, sir. While left side, we can see the various vascular changes in pulmonary arterial hypertension, showing both medial hypertrophy, intimal hyperplasia, and leading to partial or later on the complete total occlusion of the pulmonary artery lumen. The much known Heath-Edward classification of the pulmonary arterial hypertension divides the whole stage of the disease into 6 stages. When the first 3 stages considered as a reversible, while the later stages as considered as a irreversible. The stage 1 is medial hypertrophy, while stage 2 is cellular intimal hyperplasia in abnormal muscular artery. Stage 3 is lumen occlusion from intimal hyperplasia of fibroelastic tissue. Up to this stage is considered as reversible, while stage 4 is arteriolar dilatation and medial thinning. Stage 5 is the more aggressive lesion like plexiform lesion or angiomatoid formation, while stage 6 is ultimately the necrotizing arteritis or fibrinoid degeneration. Now, the WHO classification of the pulmonary arterial hypertension divides it into, it's a etiological classification and divides the whole spectrum of the disease into 5 classes. While class 1 is pulmonary arterial hypertension, which might be idiopathic, heritable, with bone morphogenic protein receptor type 2 mutation related, other genetic mutation related, drugs and toxin induced, associated with connective tissue disorders, HIV infection, portal hypertension, congenital heart disease, and schistosomiasis. While class 2 is the pulmonary hypertension due to any left heart disease, might be left ventricular systolic or diastolic dysfunction, any left-sided mitral or valvular disease, any congenital or acquired.
Make sure you move your slide before you talk. Yeah.
Class 2 is pulmonary hypertension due to left heart disease, either left ventricular systolic or diastolic dysfunction, any left-sided valvular heart disease, or congenital or acquired left heart inflow or outflow tract obstruction, any congenital or acquired pulmonary venous stenosis. Class 3 is pulmonary hypertension due to lung diseases or hypoxia. It is associated with PAH, associated with COPD, interstitial lung disease, other pulmonary diseases with mixed restrictive and obstructive pattern, sleep disordered breathing, alveolar hypoventilation disorder, chronic exposure to high altitude, and developmental lung disease. The class 4 is the chronic thromboembolic pulmonary hypertension or other pulmonary arterial obstruction. It is the mechanical CTPH, the much known CTPH associated pulmonary hypertension. Other pulmonary artery obstructions also may be there, like angiosarcoma, other intravascular tumors, arteritis, congenital pulmonary artery stenosis, or parasites. But the main spectrum of this disease is thromboembolic obstruction of the pulmonary arteries. Now, class 5 is pulmonary hypertension with unclear or multifactorial mechanism. There may be some multifactorial diseases may be associated with pulmonary arterial hypertension, like chronic hemolytic anemia, myeloproliferative disorder, other systemic connective tissue disorder, sarcoidosis, primary pulmonary histiocytosis, neurofibromatosis, other metabolic disorder like glycogen storage disease, Gaucher disease, thyroid disorders, or fibrosing mediastinitis, chronic renal failure, or segmental pulmonary hypertension. So these 5 classes was described by the WHO according to the etiological classification, these classes can be explained by where is the disease process, like class 1 PAH, which is the primary pulmonary arterial hypertension, class 2, which is the associated with sorry, class 2, which is the pulmonary hypertension due to left heart disease, the left side of the heart. Class 3, which is due to any lung disease or hypoxia. Class 4, which is the any thromboembolic occlusion of the pulmonary arteries, while class 5 may be the multifactorial as related to the all this part of the disease. Now, another types of classification of pulmonary hypertension is precapillary pulmonary hypertension. While the mean pulmonary artery pressure is more than 25 and OH pressure is less than 15 millimeter of mercury and PVR is more than 3 Woods unit. It comprises class 1, that is the pulmonary arterial hypertension primary, class 3, which is secondary to any lung disease, class 5, which is multifactorial origin patient. All this comes under the precapillary pulmonary hypertension, while post-capillary includes the left side of the heart disease causing pulmonary hypertension, or class 4, that is any thromboembolic pulmonary artery hypertension, comes under the post-capillary pulmonary hypertension. The diastolic pulmonary gradient, which is the difference between the diastolic pulmonary artery pressure minus mean capillary OH pressure, if it is more than 7, then that is isolated post-capillary pulmonary hypertension. If it is less than 7, that is both and pre-capillary and post-capillary components are mixed in pulmonary hypertension. Now, the pathology of the disease of we'll see some individual pathologies. The pulmonary, as already discussed, the primary pulmonary arterial hypertension, the early distal pulmonary arteries are involved, which are muscular arteries rather than the elastic arteries. There is medial hypertrophy, intimal proliferation, fibrotic changes, adventitial thickening, perivascular mononuclear cell infiltrates, plexiform lesions, and ultimately thrombotic lesions. Pulmonary veins are spared in primary pulmonary arterial hypertension, while pulmonary veno-occlusive disorders, the septal veins and venules are involved. There is formation of fibrotic bands, venous musculization and alveolar hemorrhage, and lymphatic dilatation with inflammatory infiltrates. Pulmonary hypertension due to the left heart disease, there is enlarged and thickened pulmonary veins, pulmonary capillary dilatation, interstitial edema, alveolar hemorrhage, and lymphatic vessel enlargement. Distal pulmonary arteries are lately involved by medial hypertrophy and intimal proliferation. Pulmonary hypertension secondary to lung disease. Distal pulmonary arteries may be affected late in group 3. Pulmonary hypertension due to lung disease or hypoxia. Medial hypertrophy and intimal obstructive proliferation of the distal pulmonary arteries are the features. A variable degree of destruction of the vascular bed in emphysematous or fibrotic areas of the lung may also be present. While in chronic thromboembolic pulmonary hypertension, there is organized thrombi tightly adherent to the pulmonary artery medial layer in the elastic pulmonary arteries, and it has replaced the intima completely or partially occluding the lumen, forming waves or variable stenosis or bands formation. Eccentric collateralized development is seen around the occluded segments. Non-resolution of the acute embolic masses, which later undergo fibrosis and leading to the mechanical obstruction in the pulmonary arteries. While in class 5 is multifactorial in nature. Now, the hereditary component of the PAH, as you already seen, there is bone morphogenic protein receptor mutation in this genetic mutation, and associated with the environmental trigger may leads to the pulmonary vascular thickening occlusion, which results in primary pulmonary hypertension. In this slide, we can see that the balance between the mutant BMPR2 receptors and TGF receptors, the balance is disbalanced because of the there is pro-proliferative increase in TGF beta receptors and mediated proliferation, while the for BMP mutation and the mutated BMPR2 receptors are less expressed, which are originally anti-proliferative. The less expression of the anti-proliferative mechanism can lead to pulmonary arterial hypertension. Then the primary pulmonary arterial hypertension, which occurs in the absence of any other diseases of the lungs, usually seen in young and middle-aged women, characterized by right heart failure. The features of low cardiac output like weakness, fatigue, edema, ascites, and syncope may be seen. On examination, we can find the prominent jugular venous pressure or cyanosis may be associated with clubbing. The palpation of the patient may indicate the right ventricular enlargement. We can palpate the left parasternal hip, or there is systolic pulsation of the second intercostal space due to dilated pulmonary arteries. In auscultation, obviously the pulmonary component of the second heart sound will be loud. See, there may be systolic ejection, click, and flow murmur in the pulmonary area. There is maybe a right ventricular S3 can be heard. In advanced cases, the tricuspid and pulmonary regurgitation and signs of cor pulmonale can be found. The primary pulmonary hypertension can be investigated by ECG, which obviously will show right ventricular hypertrophy. The chest X-ray can show the main dilatation of the main pulmonary arteries or pruning of the peripheral vascular markings. The arterial blood gases may show the hypoxemia with exertion. It can be evaluated by pulmonary function test, which may be normal or mildly abnormal, which can signify the underlying disease process with decreased the diffusion capacity. The echocardiogram is necessary for diagnosis. The right heart catheterization is ultimately the decision or for goal-directed treatment. The ECG, as we already discussed, which obviously show right axis deviation, the features of right ventricular enlargement, ROAB in V1 it will be taller and SOAB is shorter, deep SOAB in lateral leads V5, V6, tall POFs in lead 2 and right bundle branch block. The CT scan of the pulmonary arteries may indicate the etiology of the disease, which may show the pulmonary embolus, which may further show the lung disease, any interstitial lung disease. The pulmonary artery size will be enlarged, and which can indicate the pulmonary hypertension. Ventilation can also be performed, which may suggest the defect in perfusion in part or the entire lung fields, while the ventilation may be normal or may be deranged in case of any interstitial lung disease. Right heart catheterization is performed to evaluate the right-sided pressure of the heart, the right atrial, right ventricular, and pulmonary arterial pressure, along with the left ventricular and diastolic pressure. It can the Swan-Ganz catheter or cardiac output monitoring catheter may be used to measure the cardiac output. There may be pulmonary valve competence or tricuspid competence. Any septal defect, ASD or VSD, or, can be diagnosed with the right heart catheterization. The pulmonary angiography is previously taken as a gold standard for the diagnosing the pulmonary arterial hypertension. But nowadays, due to the recent advancement of the non-invasive modalities, it is rarely performed. The risk factors for the poor prognosis in case of primary pulmonary arterial hypertension, if the age of presentation is more than 45 years, the functional class of the disease, class 3 or class 4, the pericardial effusion associated with the hypertension, large right atrial size, elevated right atrial pressure, then the septal shift during diastole, the increased brain natriuretic peptide level in blood, failure to improve to a lower functional classes during treatment. These all are poor prognosis in case of primary pulmonary arterial hypertension. The treatment begins with the continuous oxygen, which is a pulmonary artery vasodilators, the anticoagulants to treat and prevent thrombosis, diuretics and low salt diets which decreases the RA pressure and treat right heart failure, digoxin which increases the cardiac output especially when associated with the atrial tachyarrhythmias, calcium channel blockers which lower the pulmonary artery pressure and may involve the right heart cardiac output, exercise, mild aerobic exercise, immunization to prevent pulmonary infections, and opportunistic infection prophylaxis, which are the patient on immunosuppression due to ILD treatment. Surgical therapies we'll discuss later. In case of CTPH, the definitive therapy of pulmonary thromboangiectomy, correct the left-sided valvular lesion, mitral stenosis when associated, repair of the left to right shunt, the atrial septostomy to relieve the right heart failure when pressure exceeds the systemic pressure. The lung transplantation is the last resort of the treatment for advanced pulmonary hypertension, not responsive to medical therapy. And it may be isolated lung transplant or combined with heart and lung transplantation. Both should receive advanced medical therapy. In class 1 pulmonary arterial hypertension, due to primary cause, which is rarely response to the primary therapies. Class 2 associated cardiac abnormality, if there is associated, it should be corrected. Otherwise, is usually worsened with the advanced therapies. Class 3 COPD response to the oxygen therapy and other general measures. Class 4, which is CTP, is responsible to mechanical thrombectomy or surgical thrombectomy and anticoagulation. Class 4, unknown effects of the advanced therapies. Primary therapy is always indicated. Secondary pulmonary hypertension. Hypoxia of any cause is the most important stimulus for pulmonary arterial vasoconstriction leading to pulmonary hypertension. Chronic lung disease, chronic bronchitis, emphysema, lung fibrosis, this may be the etiology. Increased pulmonary blood flow, any congenital left to right shunt, ASD, VSD, PDM, and leads to pulmonary hypertension. Mitral stenosis, left ventricular failure, severe MR, pulmonary thromboembolic diseases may cause pulmonary hypertension. Supplemental oxygen is always necessary in case of associated lung disease like COPD patients. Inhaled nitric oxides is useful in treatment. Anticoagulation to dissolve the small pulmonary emboli to keep INR in therapeutic range of 1.5 to 2.5 in case of pulmonary arterial hypertension patient is always useful. Now, the molecular pathway involved it is essential to know the molecular pathway because the drug treatment are directed to these molecular pathways. First, there is three important pathways. There is prostacyclin pathway, endothelin 1 pathway, and nitric oxide pathway. Prostacyclin is
Okay. Yeah.
Prostacyclin is a potent vasodilator, inhibits platelet activation, and has anti-proliferative properties. Its synthase is decreased in pulmonary arteries in PAH. Prostacyclin is a vasodilator, while endothelin is a potent vasoconstrictor and stimulates the proliferation. While the plasma levels of endothelin 1 are increased in pulmonary arterial hypertension and clearance is reduced. While in opposite, nitric oxide is a vasodilator and inhibitors of the platelet activation and vascular smooth muscle cell proliferation. Once formed, the effect of nitric oxide are largely mediated by the cyclical GMP, which is rapidly inactivated by the phosphodiesterase, especially the phosphodiesterase 5 isoenzymes. In this slide, we can visualize the three pathways of the which leads to the pulmonary arterial hypertension. The endothelin pathway, nitric oxide pathway, prostacyclin pathway. The endothelin pathway, which is mainly endothelin 1 mediated, which is acted by the endothelin A receptor and endothelin B receptors. The drug targeted therapy, we use the endothelin receptors antagonist for pulmonary arterial hypertension treatment. While in the middle, we can see the nitric oxide pathway. Nitric oxide produced by the conversion of the L-arginine to the citrulline, while it is acted upon the pulmonary circulation via the cGMP, which is further degraded by the phosphodiesterase, mainly the type 5 isoenzymes. So we can use the phosphodiesterase type 5 inhibitors, which can relieve of the pulmonary arterial hypertension. Also, the inhaled nitric oxide we use, the exogenous nitric oxide, can also act on this pathway. While the last one is prostacyclin pathway, the prostacyclin or prostaglandin I2 is the pulmonary artery vasodilator and which is a metabolite of arachidonic acid. It's the vasodilation and anti-proliferation properties can be used to treat the pulmonary arterial hypertension by the synthetic analog of the prostacyclin. That is the balance, how the pulmonary arterial tone is maintained by the balance between the vasoconstriction and vasodilatation of the various molecules. The constrictors are endothelin 1, angiotensin 2, and serotonin, while the nitric oxide, prostacyclin, and atrial natriuretic peptide are the vasodilator. While this endothelial dysfunction, which ultimately leads to the PAH, the balance between the vasodilatation and the vasoconstriction is deranged. While there is vasoconstriction, the endothelin and angiotensin 2 expression is increased, while the nitric oxide and prostacyclin are decreased. Now, the clinical feature of the secondary pulmonary arterial hypertension is almost similar picture with the primary. There is features of the low cardiac output. There is dyspnea, cyanosis, clubbing, weakness. There is features of the right heart failure with the elevated JVP and associated murmur. While investigation is will proceed with the same chest X-ray, which may show right ventricular enlargement and right ventricular right atrial dilatation. The pulmonary arteries may be prominent. In ECG, we can see the features of the right ventricular hypertrophy. In echocardiography, there is right ventricular dilatation. Some information regarding the pulmonary arterial hypertension, which is idiopathic, the prevalence is 15 to 50 cases per 1 lakh population, unknown cause, sporadic and no familial transfer. While in hereditary, there is most common is that PMPR2 gene mutation, which is involved in the TGF beta 2 signaling pathway, which is autosomal dominant trait is common. Some drugs and toxin induced PAH. Most importantly, we can see that selective serotonin reuptake inhibitors are the definitive cause of PAH. There is increased risk of persistent pulmonary hypertension in the newborn of the mothers with intake of SSRIs during pregnancy. It is evident. Other are some chemotherapeutic agents like alkylating agents like mitomycin C and cyclophosphamide may also possibly leads to pulmonary arterial hypertension. Associated connective tissue diseases, the scleroderma patients 8 to 12% may develop pulmonary arterial hypertension. The HIV patient, there is incidence is independent of CD4 count but better prognosis with counts more than 200. Associated with the portal hypertension, 2 to 6% patients shows the pulmonary arterial hypertension. The in case of liver transplant, the pre-liver transplant pulmonary hypertension is associated with the increase in mortality and morbidity, while the severe pulmonary hypertension more than 45 millimeter of mercury considered as a contraindication for liver transplantation. Associated congenital heart diseases, first is Eisenmenger syndrome, which includes all large intracardiac and extracardiac defects that begins as systemic to pulmonary shunts and progress with time to severe elevation of the pulmonary vascular resistance and the reversal of the shunt. The pulmonary arterial hypertension associated with the prevalent systemic to pulmonary shunts, which may be correctable, may be not correctable, which includes moderate to large defect, pulmonary vascular resistance.
Take the slide. It's on good slides. You're still on. Okay.
Next
Okay,
one.
sir.
You have to go to the next.
Yeah. Associated congenital heart disease like Eisenmenger syndrome, pulmonary arterial hypertension associated with the prevalent systemic to pulmonary shunts, pulmonary arterial hypertension with small or coincidental defect, pulmonary arterial hypertension after defect correction. In case of small and coincidental defect, there is marked elevation in PVR in the presence of small cardiac defect, which is effectively small but do not account for the development of this much elevated PR. The clinical picture here is very similar to idiopathic PAH, which and the closing of the defects is usually contraindicated. While PAH after defect correction in some congenital heart disease, after repair also the PAH either persists immediately or develops after months and years of correction in the absence of significant post-operative hemodynamic lesions. So there this diverse spectrum of the disease, pulmonary arterial hypertension disease associated with the congenital heart diseases. The clinical diagnosis, the symptoms may varies from exertional dyspnea, chest discomfort to the easy fatigability, lethargy, with syncope with exertion, dry cough, maybe hemoptysis, hoarseness of the voice, and lower extremity edema or ascites. The signs and symptoms of this spectrum of the disease, we can see that the signs which reflects the severity of the pulmonary hypertension may be the loud S2, the early systolic click can be heard due to the sudden interruption of the opening of the pulmonary valve into a high pressure artery. Mid-systolic ejection murmur can be heard due to the turbulent transvalvular pulmonary outflow. Left parasternal lift, right ventricular S4 or increased jugular airway in CVP, all the features of the poor right ventricular compliance and right ventricular hypertrophy. While physical signs that suggest the moderate to severe pulmonary hypertension, the holosystolic murmur of tricuspid regurgitation, the pulsatile lever, diastolic murmur, hepatojugular reflex, the right ventricular S3, distension of the jugular vein, hepatomegaly, peripheral edema, and ascites, which are all associated with right-sided heart failure or right ventricular dysfunction. In advanced stages, the low cardiac output symptoms predominates. Low hypotension, diminished pulse pressure, and cold extremities may present with advanced disease. While physical signs that suggest a possible underlying cause or association with pulmonary hypertension may be central cyanosis, clubbing, which can be associated with any pulmonary to systemic shunt, congenital heart disease, the cardiac auscultatory findings, systolic or diastolic murmur, the rails in the chest, dullness or decreased breath sound may indicate the pulmonary congestion or pulmonary parenchymal diseases, obesity, and the other phenotypic feature like sclerodermatitis, arthritis, telangiectasia, Raynaud's phenomena may indicate any connective tissue disorder. The peripheral venous insufficiency, obstruction, or venous stasis ulcer may indicate the possible peripheral vascular disease disorder or sickle cell disease. The splenomegaly, spider angioma, palmar erythema, this can also indicate the cause of as portal hypertension. The functional class in PH is same as the NOHA classification we use for the heart failure or angina. The class 1 is no limitation of the physical activity, while class 2 is mild limitation of the physical activity. Class 3 is marked limitation of the physical activity, while class 4 is unable to perform any physical activity or the symptoms at rest. The chest radiography of pulmonary arterial hypertension, enlarged right descending pulmonary artery with a diameter more than 15 millimeter. The ratio of the diameter of the right descending pulmonary artery to the trachea is more than 1.07. The bulge in the pulmonary artery with the height is more than equal to 3 millimeter. Dilatation of the main pulmonary artery as indicated by the arrows and its branches with concurrent underperfusion of the peripheral branches. Signs of the right ventricular enlargement, signs of the underlying disease and infection. The echocardiography is mainly the Doppler echocardiography is a non-invasive method to suspect and diagnose and assessment of the pulmonary arterial hypertension. The various features of tricuspid and right ventricular function, we can suspect the pulmonary hypertension. While the features of the pulmonary hypertension, we identify the right heart, the protocol for right heart assessment. We go through a detail and assess and try to assess the associated cause. Like in this slide, we can see that through echocardiography to diagnose the pulmonary hypertension, peak tricuspid regurgitation velocity is used. With the help of the simplified Bernoulli's equation, peak pressure gradient of the tricuspid regurgitation is calculated. The peak pressure gradient of tricuspid regurgitation is 4 multiplied tricuspid regurgitation velocity whole square. After that, the pulmonary artery systolic pressure is obtained by adding the right atrial pressure to peak pressure gradient of the tricuspid regurgitation, which is the right RA pressure, which is calculated by the IVC diameter and inspiratory collapse. Theoretically, the calculation of the mean arterial pressure through the Doppler echocardiography is possible, but it varies significantly from the right heart catheterization pulmonary pressure. The various echo parameters we can use to note the pulmonary artery hypertension, the estimated pulmonary artery systemic pressure, which the echocardiography, which already I told that does not equal the mean pulmonary arterial hypertension, because the definition of the PH guideline is based on the invasive hemodynamics, that is through right heart catheterization more than 25 millimeter of mercury. But we can evaluate the right ventricular size and function through echocardiography. The signs of RV enlargement, the diameters of the right ventricle, the RV, right ventricular hypertrophy, the right ventricular end diastolic wall thickness more than 5 millimeter, right ventricular systolic dysfunction, right ventricular fractional area changes, and TAPC we can assess the right ventricular size and function. Septal flattening in systole, which indicates the right ventricular pressure overload, and septal flattening in diastole, which may indicate the right ventricular volume overload. We can also evaluate the signs of the elevated pulmonary vascular resistance, which is a right ventricular outflow tract notching on pulse wave Doppler profile, which is a sign of the elevated pulmonary vascular resistance. We can estimate the volume status by the echocardiography by using the size and collapsibility of the IVC to determine the right atrial pressure. We can also see the hepatic vein flow. The systolic flow reversal in the hepatic vein can be a sign of the severe TR associated and RV overload and or increase in right ventricular stiffness. Signs of the right atrial overload or enlargement and interatrial septal motion also can be seen by the echocardiography. The severity of the tricuspid regurgitation we can assess by the echocardiography by the severity of the TR jet in the continuous pulse wave Doppler. We can evaluate the pericardial effusion associated with pulmonary hypertension, which is a poor prognostic sign. We can evaluate the cause of the pulmonary hypertension, any intracardiac shunt or extracardiac shunt we can assess, any left heart disease we can assess. We can assess the left ventricular systolic dysfunction and the diastolic dysfunction. We can assess or any left-sided valvular heart disease, any left-sided heart abnormality like cardiomyopathy, any in case of shunt lesion, if it is uncertain, we can perform the agitated saline bubble study also. We can differentiate the pulmonary arterial hypertension from pulmonary venous hypertension by different sizes and dimension through echocardiography. Coming to the treatment, the goal of treatment currently aims at the palliating the symptoms, the improving the exercise tolerance, right ventricular function, and hemodynamics. We are still striving to improve the survival rates in case of pulmonary arterial hypertension. Clinical trials of pulmonary arterial hypertension are often of insufficient size and duration to demonstrate a survival. Only recent meta-analysis of the current approved therapies has suggested durable effects on outcomes. The general measures for the patients are basic counseling and education about the disease. Low-level graded aerobic exercises such as walking is recommended, while the heavy physical exercise are usually not recommended because of it, they may evoke the exertional syncope. Oxygen supplementation to keep the saturation higher than 92% at rest and with exertion is necessary. The salt-restricted diet is advisable. The routine immunization against the influenza and pneumococcal pneumonia is advisable. The hemodynamic fluctuation of pregnancy, labor, delivery, and the postpartum periods are potentially life-threatening in patients with the pulmonary arterial hypertension, with a maternal mortality rate of around 30 to 50%. So current guidelines recommend that pregnancy should be avoided or be terminated early in women with severe pulmonary arterial hypertension, which carries mortality. The drug, based on the pathways, as we already discussed, the various group of drugs, their action on the part of the pulmonary alveolar capillary circulation, the vasodilator therapies, which modifies the smooth muscle cells and intimal wall of the arteries, while the anti-inflammatory therapies which acts on the various leukocytes and proliferative cells. The vasodilator antiplatelet therapy is also the modifies the platelets of the microcirculation, while the anticoagulants like warfarin can maintain the therapeutic INR to prevent the small emboli to form. The inhalational therapy, while acts on the alveolar membrane, which can remodeling therapies like nitric oxide and endothelin receptor antagonists also can be used. Now the pH specific therapy, if we come to the specific therapy, there are mainly 5 groups of drugs which are currently in use. We can start with the calcium channel blockers, which nifedipine, amlodipine, diltiazem. We can switch to next level drug like prostanoids, which is ipoprostenol, iloprost, the treprostinil. The next group of drug is endothelin receptor antagonists, the bosentan, ambrisentan, and macitentan, while the next group is phosphodiesterase inhibitor, which is essentially sildenafil and tadalafil, and the last one is soluble guanylate cyclase stimulator, riociguat. The calcium channel blockers, effective therapies for the patient with robust response to acute vasodilator testing. We can challenge the patient with the vasodilator challenge test, fall in mean arterial pressure of at least 10 millimeter of mercury to a mean arterial pressure of 40 millimeter mercury or less, with unchanged or increased cardiac output. If patients who meet the definition of an acute response do not improve to functional class 1 or 2, while taking calcium channel blocking agents, they should not be considered chronic responder, and an alternative pH specific therapy should be prescribed. Verapamil, which causes some negative ionotropy, should be avoided amongst all the calcium channel blockers. The prostanoids, they are one of the major mainstay of treatment in PAH. The prostacyclin, the main product of the arachidonic acids in the vascular endothelium, induces relaxation of the vascular smooth muscle by stimulating the production of the cGMP and inhibits the growth of the smooth muscle cells. In addition, this molecule is also a potent endogenous inhibitor of the platelet aggregation. Dysregulation of the prostacyclin metabolic pathway has been shown in the patient with the PAH. So the main side effects of these drugs are cough, headache, flushing, diarrhea, and jaw pain. The ipoprostenol group of the main prostanoids, the first developed was ipoprostenol, and it is very short half-life of 3 to 6 milli, and it's a limited stable time at room temperature. So it requires to be continuously administered by an infusion pump or a permanent indwelling catheter. The efficacy of the ipoprostenol has been tested in 3 unblinded randomized controlled trials in idiopathic or heritable PAH and PAH associated with systemic sclerosis. The agent improves symptoms, improves the functional class of the disease, exercise capacity, and hemodynamics in both clinical conditions. However, the survival rate increase was only observed in idiopathic PAH. The FDA approved ibuprostanol in 1995 for PAH patients with WHO functional class 3 and 4 who do not respond adequately to the conventional therapy such as the general therapy like diuretic, anticoagulation, and long-term oxygen and digoxin or calcium channel blocker. It is unusual for a patient to be awaiting lung transplantation without receiving ibuprostanol. So it is one of the primary major therapy. The subsequent level revision have included the addition of the patients with PAH related to the systemic scleroderma and all patients with the PAH regardless of etiology to improve exercise capacity. Treatment with ibuprostanol is 1 nanogram per kg per minute with a dose increasing at a rate limited by the side effects. The optimal dosage varies between individual patients and it range quite with wide variation. The next drug is treprostinil. It has a terminal animation half-life of 2 to 4 hours, which is administered either by inhalation.
Rajdeep, I think you can skip these things on individual drugs and go to the surgical management because nobody is going to remember all these things. Yeah, quickly go on. You have talked about the different classes of drugs or the classification of drugs. That would be enough.
Yes.
You know, if you remember what are the classes of drugs, that would be enough. This is more of a theoretical thing.
Okay, sir.
Quickly go on to the next. No, we don't need to know everything about all the drugs.
Okay, sir.
Yeah, this is okay. You start from here.
The rationale of combination therapy, in case of PAH, the monotherapy is frequently inadequate because the combination therapy is always helpful because in the disease process, several pathways is involved. The potentiality of the various drugs with synergistic effects is always helpful, and the severe nature of the disease always can be treated with the combination therapy. The WHO functional class 3, we can start with ambrisentan and tadalafil with class 1 indication, while the endothelin receptor antagonist and phosphodiesterase 5 inhibitors is class 2A indication. Next, we can start with a little bit of Eisenmenger syndrome. Eisenmenger syndrome is a condition that involves the elevation of the pulmonary arterial pressure to the suprasystemic level, and this is caused by the increased pulmonary vascular resistance with reversal or bidirectional.
How many more slides you have? How many more slides you have?
Sir, I'll go to there are about 90 slides, sir. So 10 more slides, 15 more slides are there. So I'll go to the cardiac catheterization and the surgical aspects. 5 to 6 slides I'll cover, sir.
Because you must edit your this thing. We can't go on and on. The attention span of everybody will be beyond 40 minutes is less. So you have to edit
so I'll
before
finish up. I'll finish in 2-3 minutes, sir. Yes. So the last option for the severe PH patient, the interventional surgical treatment, we have the option of atrial septostomy. The patients with persistent pulmonary hypertension and in whom the foramen ovale is patent, it is seen that they live longer than those without a patent foramen ovale. So furthermore, the patients with Eisenmenger syndrome that is caused by an atrial septal defects have a better prognosis than PPH patients who have an intact atrial septum. So from there, the atrial septostomy idea was born. However, the pulmonary vascular disease may occur in up to 5 to 10% of the patients with untreated ASDs, and this predominates in females. An atrial septostomy may improve the symptoms. It mainly is done to prevent the right ventricular failure and it improves the survival in the post-operative patients with advanced pulmonary vascular diseases and right heart failure, and who have no significant residual communication between the left and right circulation. The transplantation part, while successful heart-lung transplantation as well as lung transplantation with repair of the congenital heart defects might be available, there are several limitations to these procedures. Patients with Eisenmenger syndrome have a highest perioperative mortality and then the lowest 1-month survival rates among all the lung transplant recipients. The patient with Eisenmenger syndrome, the 1-year and 5-year survival rates after lung transplantation is 52 and 39% respectively. So, in conclusion of the Eisenmenger syndrome, we can say that the PAH is to a variable degree associated with congenital heart disease, and this depends on the size and location of the underlying cardiac defect as well as on the repair status. Eisenmenger syndrome is at the extreme end of the PAH that represent with or without reverse shunting and associated cyanosis. The prospects of the survival rates have improved for patients with Eisenmenger syndromes in the current era because of the advancement of the medical therapy. The new vasodilators allows the young patients with congenital heart defects to undergo early diagnosis and early corrective surgery. Eisenmenger syndrome has previously implied irreversibility and inoperability for a subgroup of patients with PH and congenital heart defects. Although there has been many advances in understanding the pathophysiology of the Eisenmenger syndrome, and also advances in treating the disease, there is still no cure of the progressive condition once it is established, aside from lung or heart-lung transplantation, which is associated with a significant morbidity and mortality. The newly developed vasodilators are well tolerated. They improve the exercise capacity and hemodynamics without compromising the peripheral oxygen saturation in patients with Eisenmenger syndrome. There I will conclude, sir. Thank you so much.
Okay, thank you. It was a fairly good presentation, but very extensive, especially with all these drugs and other things. But as a from the surgical point of view, you must know that in whenever you're discussing pulmonary artery hypertension, you must know the classification, which is very important, both the Heath Edwards and the WHO classification and the pre-capillary, post-capillary classification. Heath Edwards, only the older examiners may still insist on that, but the WHO classification and the newer classifications are more relevant. Among all these, what you should understand is which are treatable and which are irreversible stage. So you have to differentiate a patient or a child which has gone on to an irreversible phase already. And yes, during the investigation, you should focus on echo, because that is the commonest and easily available modality for assessing or calculating the amount of pulmonary arterial hypertension, and also to remember or to decide which patient can be treated either by medical therapy or surgical management. In the medical management, you talked about a whole lot of drugs, mostly from the surgical point of view. If you remember the groups of drugs and where the site of action is done, that is more than adequate, rather than going on to individual drugs and knowing everything about it. You certainly cannot remember all the drugs. That is one thing. From the surgical point of view, there are two, three things that you have to remember. As you said, rightly said in the classification, primary pulmonary hypertension is very rarely treatable by any surgical measure as well. And the left ventricular causes, the most common would be mitral stenosis. And you must remember that at whatever stage of pulmonary artery hypertension, mitral stenosis, if it is significant, it should be relieved. There is no contraindication as far as pulmonary arterial hypertension level is concerned for doing mitral surgery. Then comes
Yes.
to the left to right shunts. It is important to assess pulmonary arterial hypertension and PVR in left to right shunts, and you must try and treat these left to right shunts before irreversible damage has occurred. So there you have to calculate the pulmonary vascular resistance, both with the Wood units or the dynes per square meter